Hi, I'm Alan Moses. I'm presenting this webinar to explain the anatomic and scientific advantages of posterior stabilization in bite registration for making excellent oral sleep appliances. In this presentation, I discuss X-Slant because it is the only posterior stabilization guide available for oral sleep apnea appliances and because I invented it. X-Slant is a guide for making the bite registration, not your treatment appliance. Using X-Slant is a very simple procedure. The instruction sheet consists of 5 elementary steps. The anatomic elements that must be aligned to establish the treatment position for an oral sleep appliance, however, constitute a complex clinical puzzle. I have prepared this explanation and visual illustrations to assist understanding the numerous positional variables and their consequences. This information is provided so clinicians can understand and appreciate that the science behind X-Slant is infinitely superior to any competitive product. X-Slant is better than all anterior stabilization devices because when you use them, you are assured of parallel interdental arches. Parallel interdental arches facilitate keeping the lips together better than slant. Parallel arches facilitate nasal breathing better than slant. Parallel arches facilitate a larger posterior opening than slant, and parallel arches facilitate better neck posture than slant. Stay tuned, I'm going to tell you why. Parallel arches just make more sense. Okay, let's start out talking about something they didn't teach in dental school. They didn't teach this because dental education has been focused on teeth and surrounding tissue. Fillings, root canal, dentures, crowns, bridges, implants, orthodontics, cosmetics. Breathing was not in the defined area of treatment for dentists. But now, dentistry has met obstructive sleep apnea. Okay, so the green arrows in this picture here indicate the direction of force of the elevator muscles enclosure. The blue circles between the upper and the lower front teeth, incisors, represent an anterior interarch stabilization guide. The elevator muscles, masseters, temporals, pterygoids, are among the most powerful muscles in the body. The brain can initiate a closure signal, but with anterior interarch stabilizers, there is no posterior resistance to closure. The consequence is reduced posterior mouth space and reduced or obstructed oropharyngeal opening. The effect is known as elevator muscle squeeze. So now let's tie in elevator muscle squeeze and airway focused dentistry. The most fundamental cause of obstructive sleep apnea is a sleep-related loss of muscle tone in the tongue, causing it to periodically collapse and obstruct airflow through the oral pharynx. A bite registration guide is used to establish the interarch relationship that maximally dilates the oropharyngeal airway for fabricating and oral sleep appliances. 2 different types of interarch stabilization guides are available, anterior and posterior. Numerous anatomic factors must be considered in deciding which alternative is better. Pharynx, tongue, hyoid bone, suprahyoid muscles, infrahyoid muscles, lip posture, head posture, angulation of the maxilla to the mandible, and method of breathing, mouth or nose. On the left-hand side of this slide, we see slant. On the left-hand slide, we see slant, which is an expected result. Here's slant. Expected result using an anterior bite registration guide. There's the registration guide. there's the slant. On the right-hand side, we see parallel arches, which result from using posterior stabilization, and so we stop the muscle activity of the power elevator muscles, and it can't overclose. The net result is parallel arches. The scientific basis for using posterior bite registration for oral sleep appliances is getting parallel arch alignment. This should close the discussion. Posterior stabilization and parallel interdental arches appear to establish more room at the posterior of the mouth in front of the oropharyngeal opening. But there is more science and to scientific evidence to really seal the deal. The condylar positions are different with anterior and posterior stabilization. In the upper left, in that little corner insert, we see such products come to mind as Airway metrics, the George gauge, the tap gauge, the matrix, SOM gauge. X-Slant, as seen on the left, is new. It's the only product in the category posterior stabilization. And so we see here again slant, anterior stabilization, parallel arches, posterior stabilization. Parallel vertically lowers the condyle and the mandible more than slant. Parallel arches result in greater vertical dimension at the level of the condyles. Parallel arches result in more posterior mouth space in the area in front of the pharynx. Differing condylar positions result in different anatomic relationships of tongue, pharynx, hyoid bone, and connecting muscles and ligaments with differing consequences. Look, this point is cannot be overemphasized. The left side here demonstrates slant. The right side demonstrates parallel interdental arches. Clearly, there is more room for the tongue in parallel arches. Okay, on this slide, the instructions to the patient are lips together, teeth slightly apart, tongue in the roof of your mouth. In the top row, across the top, we have a midline sagittal slice, a CT scan. And in the bottom row, we have a coronal slice through C2, second cervical vertebrae. We have rest position on the left two CTs, and we have a Moses appliance in place on the right. Just for noting here, the interdental arch space is parallel in both cases. That an oral appliance caused pharyngeal dilation is clearly evident. We see the dilation, it's multidimensional, anterior and lateral. The tongue moved anteriorly. We could see that. Here's the genial tubercle down here, genial tubercle down here. Genial tubercle moves from here to here, and the jaw moves forward, and with the appliance in place. So the jaw clearly moved forward, and in moving forward, we see that it had a change in dimension both antero-posteriorly and laterally, quite a bit of dilation. And in addition, we have an increase in vertical height. So, but we also note in this, the X-ray in this CT, that the back of the tongue, here's the tongue, back of the tongue, right here, is the anterior wall of the pharynx. Anterior wall of the pharynx. This is interesting. The mandible gets advanced anteriorly. The tongue gets advanced anteriorly via its attachment to the genial tubercle. The vertical dimension gets increased via the Moses appliance. All three factors increase the volume of the mouth space. The airway is dilated, and the back of the tongue remains as the front wall of the pharynx. The tongue must change its shape and position to accommodate this realignment. but the tongue is a hydrostat. It cannot change in volume. It did change in shape to fill the space. The roof of the mouth and the palate continue nasal breathing, but with a dilated airway, the tongue can increase in volume, so it does increase, it does change its shape. So I explained that the muscles of the tongue function as part of the pharynx. This is the back of the tongue. This is a rendition, a CT rendition of the pharynx, and the pharynx here does not appear open on the CT scan, again because the back of the tongue is situated in the oropharyngeal opening. That being the case, the patient is nose breathing. So on this slide also I want to point out the genial tubercle is attached in the lower anterior of the surface of the mandible. And let's look again. Here's the location of the hyoid bone relative to our structures of interest here. So again, changing the shape of the mandibular position with an oral sleep appliance appears on CT scans to change the shape of the oral pharynx, dilating it laterally, vertically, and anteriorly. The tongue appears to be pulled forward with the mandibular advancement of the oral appliance, yet the back of the tongue on the CT scan remains as the front wall of the pharynx. With the tongue in the roof of the mouth, the patient must be nose breathing, and something changes the shape of the tongue or position of the tongue without changing its volume. Obstructive sleep apnea. In sleep apnea episodes, the tongue periodically collapses on the oropharyngeal airway. See it here and here, obstructing or completely blocking airflow. Apnea is a intermittent, seriously defective functioning of the nervous system. Extended blockage for even a minute could lead to brain damage or death. In an apnea episode, the tongue blocks airflow of the whole airway, nose and mouth. Humans are designed to function as nasal breathers, but there is a backup system called mouth breathing. Here we see two views of mouth breathing. The picture on the left is possibly an exaggerated view of mouth breathing with the mouth so wide open. But on both mouth breathers, the tongue is not the front wall of the pharynx. Lowering the tongue position can create a more patent oral airway. Oral breathing can occur with the tongue in the floor of the mouth. However, nasal respiration provides the most efficient mechanism for introducing oxygen into the lungs. Mouth breathers have a lower oxygen concentration in the blood than nose breathers. Mouth breathers have a higher rate of cardiac disease than nose breathers. Mouth breathers have a higher rate of obstructive sleep apnea than nose breathers. A successful oral appliance should not create a mouth breather. The problems with slant. To achieve adequate posterior airway patency, the anterior of the mouth may be over-opened. Over-opening at the anterior may separate the lips during sleep and create a mouth breather. The position of the interdental arches in a mouth breather is slant. Mouth breathers typically have a more forward head posture than nose breathers. Slant reduces posterior mouth space compared to parallel arches. Slant is not a good position for an oral sleep appliance. So, I have differentiated parallel from slant, explained tongue position and movement relative to oropharyngeal opening, and the relationship of slant to mouth breathing. But there's more. The importance of proper hyoid bone positioning. A well-fitted oral sleep appliance dilates and stents the pharynx anteriorly and laterally. The hyoid bone is the only bone attached to the pharynx. There's your pharynx here, hyoid bone. So, if the pharynx is going to dilate, it has to relate to movement of the hyoid bone in an anterior or maybe lateral position. So, the position of the hyoid, pharynx, tongue relative to each other affects airway patency. The hyoid bone is the ultimate positioner of the head on the spinal column. The hyoid bone floats like a pulley amid 6 sets of muscles that attach to the superior surface and 6 sets of muscles that attach to its lower surface. Everything is interconnected, and that's the important thing. But for reference, and this is not going to be a test, but infrahyoid muscles of particular concern are the sternohyoids and the omohyoids. And the suprahyoid muscles of concern are the digastrics, stylohyoids, mylohyoids, and geniohyoids. So you can see these ones that are above it. And then the point is that they can pull it up, down, forward, and backward. The hyoid bone is the center of action for most movements of the pharynx, and therefore it affects airway patency. The higher the hyoid position relative to the spinal cord, the more cervical curvature and poorer the head posture. Mouth breathers have a higher hyoid bone position and a more forward head posture. A low tongue position means high hyoid position. The more flexed the cranial base, the less space for the tongue. Negative hyoid triangle results from slant. The slant situation, where there's a slant, results in a negative hyoid triangle. With a parallel arches, we get a positive hyoid triangle where the hyoid bone is lower and the posture is better. So let's summarize. With anterior stabilization, we have elevator muscle squeeze, which we've explained, and that equals and leads to slant. Mouth is over open in the anterior. The mouth space is reduced in the posterior with slant. Oropharyngeal patency is reduced, and this may make it difficult to close the lips. A big opening in the front, smaller in the back, difficulty opening the lips. The TMJ is placed in abnormal biofunctional position, and now we know that there's an unfavorable change in hyoid position. We have a head forward posture with anterior stabilization, the increased neck curvature, and it reduces tongue posture. So this is all more likely to create a mouth breather. Posterior stabilization with X-Slant, we have parallel arches, lower posterior mandibular position, or optimal pharyngeal dilation, optimal tongue position relative to oropharyngeal opening and soft palate. Hyoid is level relative to the cervical spine, C3, and facilitates posture and breathing. Excellent physiologic positioning of the mandibular condyles, discs, and glenoid fossa. And posterior stabilization supports nasal breathing. And again, avoids elevator muscle squeeze. Okay, the conclusion. Airway-focused dentists have a significant range of control over pharyngeal size, tongue positioning, breathing mode, be it nose or mouth, hyoid bone positioning. All of these factors relate to why you should be using posterior stabilization guides for bite registration. and X-Slant is the only commercially available posterior guide. Okay, I have just presented a lot of anatomic science to explain an innovative and better method of bite registration for oral appliances. You may purchase X-Slant kits on the Moses.com website. I would appreciate your feedback, and I am available to answer your questions by email. Also, dentists, you may request a courtesy professional sample by sending your complete mailing address to Alan at themoses.com, the address on the slide. Good luck in your practice of airway focused dentistry. Adios.